Mary Jane. My name is Joe Spurgeon from Lindbergh and Ripple. We're the insurance consultants. So amongst all the budget stuff that we help with negotiations. We also do a lot of day-to-day stuff. My colleague Ashley works hand in hand with Mitch and Sharon over at the Board of Ed. Just about every day, unfortunately, dealing with issues. So we'll talk about kind of that role as well when we get into kind of next steps. But so first, before we kind of dive into the presentation, I know you guys know the number is big. I'll jump ahead a little bit and say a lot of it's large claimant driven. It's driven by a few members, employees, or spouses that have very large claims. That is what's driving the problem, but we'll talk about that. Before we get into all of that, I think you probably all understand that Guilford is self-funded. You are one risk pool with the Board of Ed. So all the numbers I'm going to talk about today are both town and board combined. You cover your active employees as well as retirees on the plan. And so active and retirees are on this plan. The only people who aren't in this plan would be over 65 Medicare supplement folks, a handful that are on the town side. Those are not in here. But for the most part, actually, some of their claims are, their drug claims. Some of their claims are, but not all of their claims.
Only 17 people.
Yeah. So this represents kind of your whole population. The claims I'm going to talk about here are medical, drug, and dental claims. Okay, so it does include everything. As a self-funded group, you are liable for all your own claims. You use Anthem as a third-party administrator. Anthem really is just paid to administer claim payment for the claims that are incurred by your employees. We use Anthem's network, and thus we get Anthem's discounts that they negotiate at their network. So all their hospitals, all their doctors, all their pharmacies. And Anthem does all the customer service and produces all the plan documents. Okay. But for the most part, you really are your own insurance company. We will talk about stop loss in a little bit as well. As a self-funded group, you do. Yep. Oh, that was a hand going.
Oh, I'm sorry.
No, it's okay. We do have stop loss, which protects us against very large claimants, and we'll talk about that because that'll be a key piece of our conversation today. So as we walk through this, Mary Jane, we're going to spend some time talking about how we get to these projections, and the way we get to these projections is by looking at your historic claims. Okay, so the best indicator of future costs is really your most recent 12 months of claims, and that's what we use to do budget projections. I'm going to walk you through both claim history and also actually show you the actual projection, right? So you guys have a better idea of what's kind of going on here. The first page of the presentation looks at some claim history. I'm not going to go through every single row of data, column of data here, but this is something we review just about monthly, every other month during the budget.
But I hate to interrupt you, but
yeah.
there's a word that keeps popping up. What's laser?
Laser. We'll talk about that.
Okay,
Yes. Yeah.
sorry.
That when so I referenced stop loss.
Yeah.
We'll talk about that.
Okay.
Yep. That's a very important piece of what's going on here today.
New term
Yeah.
New term for some. Yes.
for us.
For public sector in Connecticut specifically. Yes. So claim history. On this page, we are reporting what we call net paid claims. What a net paid claim is I mentioned before, you have stop loss insurance. So as part of a self-funded group, you say, hey, we're going to absorb all our risk, but we want to buy some protection. So if any one claimant exceeds a dollar threshold, yours happens to be $150,000. If any one claimant exceeds $150,000 in total claims for the policy year, then that becomes the liability of our stop loss vendor. The stop loss vendor just happens to be Anthem. Okay, it doesn't have to be Anthem, but it is Anthem. We'll talk a little bit more about that in a little bit. On this page here,
Juice, I'm sorry.
that's okay. On this page here, we're reporting net paid claims. What that means is only the claims that you're liable for. If there's a claim over $150,000, anything over 150 is not in these numbers. It's just what your liability is. And a couple things just to kind of point out, we do this by month. As we migrated, somebody mentioned earlier before we started the meeting about migrating to the HSA plan. As we migrate to the HSA plan, one of the things that happens with HSAs is because the deductibles, right? And so now I believe every union, not in all this history, but every union now is in the HSA. We have this effect called the seasonality of deductibles or deductible seasonality. And what that means is in the beginning of the year, as employees are incurring claims, they're paying those claims because it hasn't hit their deductibles yet. This reports just your liability. So any employee cost shares aren't in this. So we always expect, especially in these last two, maybe even the third columns to the right, those first few months of the year are going to be lower than the rest of the year because employees haven't met their deductibles yet. Okay. And that's just something to kind of understand when you're looking at numbers. And we'll talk about that on the next page as well. A couple things just to point out real quickly. One thing I think you really want to point out is if we look at, I want to compare 16, 17 to 18, 19. For those of you in your non-governmental roles, in your employment roles, one thing you probably are aware of with your own employers is that healthcare costs go up, right? Every year, healthcare costs go up. One thing you'll notice here is that 16, 17, and if we added columns on before, probably higher, you were at almost $7 million in claims. If you look at 18, 19, I'm just going to stop there for a second before we go to the columns to the right. If you look at 18, 19, you're at 10 million 3. That really is a function of all that migration to the HSA, right? So that's those years that we migrated first the Board of Ed. The teachers weren't the first union to go, actually. Usually we do see teachers go first. It was the non-certifieds at the Board of Ed that went. And then the teachers followed. And then the town kind of in between, Mitch, what, I guess in 18. So we first started moving those over, right? So that kind of reduction of claims is really a reflection of that migration to the HSA. And it does have some impact on how claims are actually being utilized. But a lot of that is a result of the work Mitch's team does and the Board of Ed teams does during negotiations. So even though we are talking about a bad year this year, I think when we look at total claim dollars, if you compare back, 5 years ago, we're still actually running pretty well in comparison. All I do is work with public sector groups. I get that that's great to know, and that's good work that you've done, but that the impact on one budget year doesn't matter what we spent 5 years ago. It matters what's impacting this budget now. But I just bring that up to say the work you've done is the right work, okay? Just a couple other highlights on here. 1920, very low year. That was our COVID year. If you look at the last 3 months of that year, April through June, you can see they're very low. What happened April through June? We had a shutdown. Really, it was March, but really April through June, those reflected in claims. We had a shutdown, right? Even the healthcare system shut down for non-emergent care. What we saw was we had a lot of either deferred or avoided services in those months. What's a deferred service? A deferred service is I had a knee replacement scheduled on April 15th. I couldn't do it because they weren't doing elective procedures. I had to have that scheduled at some point in the future. Most of those deferred services have been made up, right? So we're not really worried about some big influx of all deferred services hitting the claim system anymore. Those have been made up in the following months since then. But we also had what's truly called avoided services. What's an avoided service? An avoided service would be people weren't going out. They weren't getting in car accidents. They weren't having heart attacks as much, right? They weren't doing anything. They weren't breaking legs. So we saw a significant decrease in emergency care primarily that really reduced urgent care, that really reduced costs in those months. To some degree, unfortunately, we also saw a decrease in preventive care in those months. We're starting to see that come back up again, right? That's something we don't want to see a decrease in as a preventive care. We want to see our preventive care go up. We are seeing that come back. So that's why that 1920 year was so low. 2021, you jump back up $1.8 million. What I will tell you is that that was a big jump. If you talk to other people in your positions at other clients, what you will find is that their 1920 year was a great year and their 2021 year was a great year. You returned, quote unquote, back to normal and actually even exceeded 1819 quicker than most of our clients have. And a lot of that has to do with large claimants. And we'll talk about that on the next page.
And some additional staff.
No, let's see. Well, we can show that on the next page, actually. I want to see if there's anything else in claims. So just one comment. So year to date, in this very last column, a couple things to point out here. You'll notice November was the last month of data, so we're updating with December data very shortly. Mary Jane may have a couple comments on that. We've done the projections. When we talk about the projection coming up, we've done the projection through November. November was a very low month in comparison to if you look at the last running even year. July was actually pretty good too. November was a very low month. I am a little worried that that's an anomaly month. That is part of our projection. So once we kind of look at December again, we'll have to kind of relook at things. Anyway, it's just important to look at the average. You'll notice year to date at the very bottom, right? Our average is below 2021. So I say it's a good thing. Again, I would just bring up the point that deductible seasonality, right? We know that these first 5 months of the year, 6 months of the year are going to be lower than the second part of the year. So I don't want to take too much credit in us running low right now. If you just average July 20 through November 20, we averaged about 753,000. So we're about 14% over that if you average the current year to date. Okay, so we are running higher than last year. Next page, and then I'll open for questions after I go through this page. Next page is just kind of a summary of this, but then we talk about large claimants, and that's what's really important and part of this conversation. So the first line on here is what we expected claims to be. This says Anthem expected claims, and that's typically what it is. But as a self-funded group, we actually work together as a group on what the budget amount is going to be. It's very rare that our claim projections aren't pretty close to Anthem's. And Anthem is, when Anthem does their claim projections, that's what we use to determine the employee contribution rates. So we tend to try to get to Anthem's number if we can. We'll do 3 or 4 projections before we even get Anthem's initial projection. We'll do projections after Anthem's projection. So we constantly look at that. But these are the kind of budget base of the claim projections. In the second column, or second row, sorry, in the very last column, you'll see there's a number below that, right? So if you look at the Anthem expected, it's 11.32 million, and then you'll see below that 4.717. That's just a straight annualization. So if you take the 11.3 divided by 12 and then multiply it by the 5 months of the year so far, that's where we are. That does not take into account deductible seasonality, right? That's just a straight annualization of where we would be year to date if we expected claims to work out on an average basis. We then bring in gross claims. So on the previous page, we only talked about net claims. Here we bring in gross claims. So this is all of your claims, including those claims for anybody that was over $150,000. The next line I then do is I back out anything that was over $150,000. And I just want to kind of walk through from the far left, right? You had 1.9 million, 1.5 million, 1.8 million, 1.4 million. And then actually went down a little bit in 2021 to $1 million. I'm going to bring that up in a second when we'll look below at the stop loss premiums. Below that, I then the plan year differential, right? So we had we outperformed projection, right, by 1.57 million, or almost 12%. The next year by 17%, another 17%, 19, 20, 23%, and then last year by 3.34%. Let's talk about that for a little bit. One thing that you guys decided to do, which I think was prudent, and it set us up well for what we're going to talk about in this budget cycle, is with that migration to the HSA, you did not take all of the projected cost offsets. So when we sit down to do negotiations, we price out what is the current plan projected to cost us. If we move to the HSA plan, what's that projected to cost us? And the opportunity for savings was actually bigger, right, than what you budgeted. And one of the reasons why is because you hold that risk, right? So if Anthem says, yeah, it's 15% less expensive to go from a copay plan to the HSA plan with a deductible, you bear all that 15%. You get 3 or 4 large claimants, that absorbs that cost offset. So you guys took the position that you weren't going to take significant cost offsets reflected in those negotiations, and instead let the claims experience kind of show how that's true. So you might say, well, did we over budget in those years? To some degree, you may have, but that sets you up now where your claim projection, your claim reserve is in a good position to kind of absorb some of this, right? So you've kind of put that in, you kind of paid yourself your reserve with the opportunity for savings that you didn't take in the budget. Going into 2021, you'll see we were 3.34% under. A lot of my clients in the public sector were double digits under expected again last year. Okay. So even though, well, 3.34 was good, we saw a lot of clients that stayed well under projection. We'll show you how we come up with the projection in a second, which takes into account lots of things. Year to date, you're running 11% under expected. Again, what I would say right now is I'm not overly worried. December might throw us off a little bit. I'm not overly worried that we're going to end well over expecteds this year. Almost halfway through the year to be 10% under expecteds would tell me you'd probably end near expected if claims stay at that same level. We then bring in, you see the far left, the column header ISL premium. That stands for individual stop loss. So those are the premiums that we paid Anthem. So the comparison here is if you look in the first column, you see $886,000, right? If you compare that to the 1.893, so we paid $886,000 in premium, and Anthem paid out almost $1.9 million in losses. So Anthem lost $1 million. That next year you paid 1.2, almost 1.3 million. It was a little better for Anthem. They still lost money. The third year, 17-18, you paid 1.3. Anthem paid almost 1.8. Now what you can see is premiums really caught up. We paid almost 1.8 million, right? Hard to argue with Anthem that our stop loss doesn't need to go up. And then we saw a reduction in stop loss losses. So Anthem is starting to make money now. And then last year they did very well, right? So it's kind of circling back to where Anthem's doing well. We'll talk more about that in a second. But what you'll see, right, is that those last 2 years, the two completed years, so the 19-20 year and the 2021 year, where Anthem did make money on those stop loss premiums, you can see that our stop loss did not go up much for the current fiscal year, right? So part of our negotiations when we talked to Anthem is, hey, here's what's going on. What should that stop loss pricing be? And we were able to negotiate a somewhat favorable increase. Not that $2 million a year in premium isn't a lot. Just to talk about that for a second, the way I look at stop loss is it's a measure of risk, right? So clients will, I don't have any self-funded clients that don't have stop loss. The state of Connecticut doesn't, as one example, but most clients, most public sector groups have stop loss. You're basically paying for protection to protect your reserve funds, right? And what your reserve fund does is it protects your general fund, right? So if you look at it from a public sector perspective, you buy stop loss insurance to protect your internal services fund, so you call it, Mary Jane? Mm-hmm. Your internal services fund, which in turn protects your general fund, right? We could cut that stop loss premium in half, right? What that would mean is we're going to raise that stop loss attachment point, right? So instead of $150,000, we have to go to $300,000 or $500,000, right? That would reduce our premium, but then we'd accept more liability, right? Which would be a balance. And that's something we will do and we have done just about every other year, maybe every third year. We actually made a change just prior to so I think it was the 15-16, right, Mitch?
Yeah, I think it was about that.
16-17, we moved from 175. We didn't include drugs under stop loss. In 16-17, we moved to 150. So we dropped the stop loss attachment point and we added the coverage for prescription drugs. So that was a move that we made. Actually, one of the first things we did when we came on board is do that. Let me talk about the net catastrophic claims, then again, I'll pause and see if there's any questions on claims before we get into the projection. Actually, I might do the next page and then I'll let you go because that kind of summarizes some things. Catastrophic claims, real quick. We define a high dollar claimant or a catastrophic claimant as anybody with claims over $150,000. And here I said dental before, here I'm just looking at medical and drug. Okay, so if somebody has claims of $150,000 or more for medical and drug, we're gonna call them a high dollar claimant. And what we do is we track those claimants separately from your non-high dollar claimants. So you can see, right, if you look in that first column, of that almost $7 million in claim liability, right, in your net paid claims, 4.2 of that was for high dollar claimants. The rest was for non-high dollar claimants. And you can see what that is going down the line. It's probably easier to see if you look down below. So the next line down there, you'll see 1,490, and that's average experience period members. What a member is counting everybody who's on your plan once throughout the year, and then we average it. So you had almost 1,500 people in 16, 17. That would include myself and my dependents. So when I'm counting here, I'm a family of 4. All 4 of me are in this number. Okay. When we talk about the projection, I look at contracts, and there I'm just counting the employees on the plan. I'm not counting the members on the plan. So we'll talk about that in a second. So one of the questions was, did we have more people on the plan? We have consistently gone down. We are up a little bit year to date versus where we were last year. Now that's members. Sometimes that can fluctuate, right? So you may have, you might lose more members, but not as many employees because people age off the plan or people retire with dependents and you hire single people. So that number changes a little bit. So I wouldn't compare that necessarily to employees. That's also just who's enrolled, right? So you guys do in Guilford have a lot of waivers. You have a lot of employees who don't take the insurance here. I don't remember the percentage off my head, but the board does as well. So not all of your employees are enrolled in the plan. They have coverage elsewhere. Interesting numbers below. So if you look in that first year, 36% of your employees, 3% of your employees were driving 36% of the cost, right? And that's been somewhat consistent, right? We're in that kind of high 2% driving in the mid to higher 30s, even into 40%. And again, that last column, right? It's only a few months in, so don't take any credit in that 1.12% so far. And then down below, you can see your largest claimant. Right. So in the first 2 years of this plan, you had like one claimant, right? That was over $1 million in both of those years.
Does it, when that number is what Anthem actually pays?
Yes.
So it's not like the submitted bill.
Correct.
Eight times
Anthem's negotiated amount. Right. So like that $1.2 million claimant was probably a $3 million claimant. Right. It's that ridiculous sometimes.
So that's what we pay.
Yes.
To Anthem.
Yes.
Okay, thank you.
You're welcome. Okay, next page, and then
That would have been covered on stop loss.
what's that?
That actually would have been covered under stop loss.
Yeah. So on average, we see and large claims are a whole different mess, to be honest with you. But on average, we would say claim discounts are probably around 50%, right? At the hospital, and then they're a little lower than that. And then at the doctor's office, it's probably around 30%. So if you have a sick visit at your doctor, average cost is probably about $110. If the bill is probably $200, right? And Anthem just negotiates that down. Or the whole debate, right? I mean, is it really $200 or is it really 110? It's really 110, right? Because nobody's paying 200. Even if you don't have insurance, right? You're not paying 200. So
Only the uninsured pay full bill.
yeah, and they don't even.
They get squeezed.
Yeah. So that's a whole mess, right? That they are working on cleaning that up. There's lots of ways, and we can talk about that if you want after. What I wanted to look at here, and again, just this next slide, expected claim history. This isn't your actual claims, they're expected. And I just wanted to show kind of the transition of where we were. So even though we're having a bad year, right? Kind of when I started off. This one is confusing. Yep. I just wanted to show the percent change in expected claims year to year, right? So in 16, 17, the first column on our previous sheet, right? When you compare 17, 18, we were up 1.64% in expected claims, right? That next year, that was down 7%, then down 4%, then down 5.69. So one of the things I think that I heard the board ask, and so this is kind of a board question, was, we've had so many years of things going down. Dr. Freeman, I think, said this was one of the first times he's had to present where healthcare is I forget what the exact number was.
Driver.
Well, and it's the major driver, right? It's the biggest portion of his increase this year. And so one of the questions the board has, well, why is that? We've always seen it where it's helped our budget, not hurt it. So we just wanted to show that there was, yes, we'll acknowledge we were doing very well in the past. One of the things that's happened is now that we are all HSA, right, our base is reestablished. We aren't going, HSAs don't have a negative trend, right? They just reassign the base. And so what's happened up until last year into this year is we've had HSA migration each year with different unions moving to the HSA plan. We're kind of out of that now, right? I think, Mitch, we've got a couple unions, police.
No, everybody
Everybody now?
HSA except for 2 individual contracts and 3 remaining members of the GEA, they're grandfathered.
And then lastly, that very last one is just comparing the 21-22 projected claims at 11.3 to the 16-17, right? So you're down almost $2 million or 14% in what we expected those claims to be, right? So hopefully that just kind of helps set why of all of a sudden our things change, right? It just kind of helps set that budget. So I'm going to go into the projection next. Before we do that, are there questions on claims? You understand kind of how those moving pieces and then are going to impact our projection, which we'll talk about next.
What's the cutoff for high dollar claims?
150.
That's the stop.
That's your stop loss attachment point. Yeah. And that's medical and drugs. So dental claims aren't ever very big. So we don't include dental.
One of the things I think we have to realize is the Board of Education came in with very lean budgets over the past 4 years, largely on the backs of healthcare costs being done. And because I think there was some shifting of the membership, and they wound up doing very well in a period of time. So I think Dr. Green is starting to talk about this as a long term. This is why we're going through this exercise to make sure that the messaging out there is, this is a long term effect from what we have done, and he's trying to get folks to don't look at it as one budget.
Great.
I may be the only person in the room, but if I had to explain to somebody why the healthcare goes up, it sounds like it has to do with the HSA, and that seems antithetical to why we went to the HSA. So you probably said it, but I'm not getting it.
We're still paying less, anticipating paying less for 21, 22 than we did in 2016, 2017.
But something's gonna
assume-
happen.
but assume for a moment that general healthcare costs have gone up by 5% a year. All right, 13.2 should be
Yes.
25% higher than that number today. So baseline, take 2016, 2017 as base, and assume the healthcare costs would go up 5% per year. I don't know if that's a good number.
It's even a little low, but let's just use that. Yeah.
Okay, 5% per year, all right? So that's 1, 2, 3, 4, 5 years. Basically 25% should put some compounding in there, but we
Yep.
won't. So the cost from today for 22 should be what?
Close to 15.
Another 17, no, 17.
17.
Okay, so that's where the HSAs have been beneficial.
Yes.
We've controlled the cost curve.
Yes.
Haven't reduced it, we controlled it.
Yeah.
Well, we actually have reduced.
I mean, yeah.
But not permanent.
No.
I think, Sandy, as we go through the projections, you'll see the reason is mainly the high, the stop loss people that are driving the increase here. So I think the next section is going to talk about where our budget is going this year, and that might be clearer to you
All
as to an
I'll
answer.
wait. I mean, that's good.
Right, because right now, we've only talked about where our costs are.
Okay.
And
Yeah.
so as we move forward, I think it'll become a little
All right.
clearer, and we can, come up with some talking points that you'd have out in the public.
Yeah, and another way to kind of think about your HSA migration is if trends 8%, right? So if predictive trends are 8%, and you were moving 100 or 200 employees every year to the HSA, what we were able to do is you were able to kind of mitigate that trend, right? Reduce it from 8 to something else because we've made that change. What I'm saying is now that everybody's in the HSA, we won't have further trend mitigation, right? Because the base is now all HSA. We won't get that one-time big savings anymore. Another way to kind of look at that would be if you were a private sector employer, right? In 16, 17, your claims were 13 million. You would moved all your employees at once to the HSA and dropped it down to 11.3 in 1 year. And then you wouldn't have that trend mitigation thereafter. Because you have collective bargaining agreements, right? It's about every 3 years that you're kind of doing that. And it's not everybody in the same year, right? So it's kind of working those through.
But I guess the other thing is, I think looking at it, if we started everybody in the PPO plan, where would we be right now?
Yeah, and so Matt's good point, Mitch, because that 8%, right, is really kind of an average trend with an HSA trend, right? So copay plans would have been a higher trend than that. So Mitch, you might have been more like 12% a year if you stayed in the copay plans. So that's a good point. And there are drivers within the HSA that make those plans trend less anyway. So if what we do know about HSA plans is because of the deductible, people tend to use a lot more generic drugs than brand name drugs, and we see a lot less ER utilization. It's not because people still don't get hurt. It's because people say, you know, I twisted my ankle. I'm not going to go to the ER. I'm not going to Yale ER. I'll go to a walk-in center instead because I don't want to pay $1,000. I could pay $150 to have my ankle wrapped. So those types of things are still there, but we just won't have another major reset of the base. Okay, so projection. I agree with Mary Jane. I think this might help kind of understand what's going on here. So this is the snapshot of how we do our projections. Behind the scenes here is a huge giant spreadsheet that does a lot more work. But to be honest with you, it kind of boils down to this. There's two main columns on here and then some notes. The first column is our current budget year, right? So it's 21, 22, the current budget year. It was the projection we used to set this year's budget. The second column is the projected year for 22, 23. There's three main boxes here. The top box and the third box are really what does most of the math here. The second box is really just informational. The first thing you're going to notice in the top box, in the first column of data, is that you'll see experience period through October 2020, and then you see next to that November 21. So those were the claims that we looked at when we did the projections. So you might say, well, Joe, earlier you said you guys do projections throughout the year. Why did we use October claims, right, if we set the budget in February or March? And it's because as we did updates, there wasn't any significant changes. And so what the board already had out there and what you guys had already started working off of seemed to be appropriate. So that's the data we used. When we did the initial projection, we actually had a month more data this year, so we used November. And there's an impact of that below, and you'll see that. But the first thing that we do is we bring in the gross claims. So again, that's all claims, right? It's the claims for me. If I'm a $300,000 claimant, it includes all 300,000, not just the 150. And then last year, you'll see below in the first column, 1.0914. That's what we call a completion factor. And what we did is we knew, right? So in that experience period, in that 12 months of claims through October, we had April through June. We knew those months were artificially low, right? So I can't do a projection and say, oh, we're going to use those months and project those into a year where I don't expect that to happen again. So we have to adjust those claims. And so in underwriting and actuarial terms, we call that a completion factor. And in essence, what we try to do is say, if April, May, and June were normal years, how much more would they have been? And that's 9%, right? So if I multiply my gross claims by 1.0914, that's increasing those claims by 9.14%. Okay? And the way we got to that factor, just so you understand, it's real data. We looked historically, some of this is Anthem too, but we looked historically at your April through June claims and said, what were they normally as a portion of the full year, right? And then how would that kind of factor out? So that's kind of how we come with those factors. So for last year, we took the gross claims and we increased them by 9.14% and got that 11.75 million number. I'm going to jump over to the next column. Gross claims are way up, 13.52%. But we aren't doing a completion factor, right? We don't expect that there's lingering claims out there that we need to account for. We don't need to complete anything. So that's just a 1. And so our adjusted claims are 12.2 million or only up 4%. Somebody say, hey, so far, not bad, right? What's going on? We then back out any of our large claimants. I'm sorry. That next line, less non-enrolled large claimant. Let me speak more clearly about that. $234,000. Right now, we have somebody on the plan, a large claimant on the plan, who is no longer enrolled in the plan. So when we do the projection, right, they're in those claim dollars. And so in this mechanism, what we're doing is we're taking that member out of the projection altogether, okay? It's a standard underwriting projection that we do. Depending on the number of large claimants, sometimes we will. Like if you had just one large claimant and that person was no longer on the plan, we might not take them out because we might think, hey, somebody else will take their place. But you actually have 6 people over stop loss on the plan. So we figure we could take one out and it wouldn't be, it wouldn't be too risky. So we're removing that claimant altogether. We did not do that in the current budget year.
So Joe, just a quick sanity check. Is that an actual person that we know is out?
Correct. Yes.
Mortality tables, whatever, or?
Yeah, the person's no longer enrolled in the plan. It's an actual person of $234,000 in claims. So we took out all of their claims.
That's been real live body.
Yep, real live
Or
body.
maybe dead.
Yep. And so we then have adjusted claims. We then back out all of the excess claims, right? So we're still talking about gross claims here. We're going to back out any claim that's over that $150,000. And the reason we do that, right, is you're only liable up to $150,000. Why would I project your liability with claims more than $150,000 as part of the projection? So note right here, you'll notice we backed out $1.5 million in large claims, in excess claims, and now we're backing out $793,000 in excess claims. So we're backing out fewer claims over stop loss.
So wait, so in this year, we paid 1.9 million in premium and you're only projecting 793,000 in claims?
No, so this is actual 12 months through November, right? That previous page is projected for the full plan year. 2 pages up, sorry, the 1.9, yep. So this is using 12 months through November. Right, that is premium you're paying for the full year, July through June.
Yeah, 1.9.
Yeah.
Okay.
We do know, right, what we're expecting, right, is that, and we'll talk more about it in a second, but what we would expect, right, based on the last 2 years, if you go back 2 more pages, right, we've seen a decrease in our large claims. One of the problems that we have, right, is when we set budgets, is we're not using claims at the end of the year, right? We're not using June 30th claims to predict your next budget year. We're doing claim projections now. So we're looking at losses, right? So if you look, if you compare it to Anthem to what we backed out last year, right, that's probably a more fair comparison, is that 1.5 million
Yeah, but
compared to the 1.9.
I'm confused about the 793.
So one thing to take in mind is the 793 plus the 234, because that 230,
Well, plus not all of it,
not,
Yeah.
right, not the
Yeah.
150, right, but
so 80,000 of it.
yeah, so that some of that is in that number as well. So if the 234 number wasn't there, part of that would be down below.
Yeah,
So instead of 800, it might be 900,000.
But I just want to understand that 793 is what you're plus this one, no
Right.
longer included person. Is what our projected stop
No.
loss benefit is
Nope.
going to be for the year?
no. So the
Which-
1.9,
since it's really
the 1.9 that we're paying today,
Yeah,
right, is really more a function of the first column, right? The first column sets the budget that we're in today.
sure.
The 793, which is really about 880, call it 900, right? That 900 is predicting what we're going to pay next year. Right, this is not,
2023, okay.
right, so this is, so for
I
example,
got you, I got you.
Got
So
it.
the 1.5 is against the 1.9
Yeah.
million.
Yes,
Yes.
behind it 1 year.
But next year, you're predicting a relatively low,
we're not, but I'll explain why. But
Okay.
yes, yeah, if
at least
you,
on that number.
based on that number, you'd say,
Lasering
great.
is going to come into play.
Laser, I knew it was coming.
Yeah. So you're right with me, right? You'd say, hey, great news, right? We're going to see a very little impact, maybe even a decrease, right? I'd be significantly arguing for a decrease in stop loss based on where our losses have been historically and where they look at based on what we have losses now. So you're right with me, but we'll talk about what's kind of going on. And there's a couple other things going on that I'll give Anthem a little bit of credit on, not a lot, but a little bit. So then what happens, I create my base, right? So that in the first column, 10.2 million, that just backs out those excess claims. And now we're 11.2 million. So we're up almost 10% in these 2 periods. I then bring in my experience period contract. So that's a term I referenced a little bit earlier. So a contract is just counting your employees. And the reason why that number is so big, you don't have 6,293 employees on the plan. This counts everybody once for each month that they're active over the plan. So you have 530-ish on the plan. The reason why we do that, right, why we use that bigger number instead of just saying divide it by 530 is because those 6,293 people each month incurred claims each month through November, right? So we're trying to create a per capita and compare those two, those enrollment figures together. We then just get our per capita, right? So you can see our per capita is 1611 in the first column and 1779, so up 10.43%. So it's up for a couple of reasons, right? It's up because the net claims, the paid claims less excess, is 10% higher, but we also have fewer members, right? So fewer contracts. So I'm taking a larger number over fewer contracts. So in this projection, so note number 1 in the top box, Anthem assigned $450,000 in lasers on 2 members. The large claim adjustment backs out 2 laser claimants at the current laser stop loss. I'm going to explain all this. See build section below. So let's talk about lasers, then I'll talk about what this whole note means. But what Anthem has proposed, and it's not just in Guilford, it's a new thing they propose, is a stop loss laser. Stop loss lasers are a very common feature of stop loss policies in the market, right? So it's not a term that's new to me. I've known of lasers since I got into this industry. It is new in the Connecticut public sector. So historically, Anthem and Cigna, the 2 major providers, major carriers for public sector plans in Connecticut, did not implement lasers. So what is a laser? A laser is, stop loss vendors will tell you that stop loss is like home insurance, right? Stop loss is used to protect against unknown risk, not known risk. And so if you have known large claimants that occur year after year, or they expect to occur year after year, then our stop loss policy isn't really for that, right? It's to protect you against unknown risk. And so they'll put lasers on these individuals. And what a laser does, it says, okay, we're going to say Joe is an expected large claimant that's going to occur year after year. We're going to put a laser on Joe. So instead of Joe being 150,000 in stop loss, Joe's going to be 450,000.
Insurance companies, in case anybody wants to understand
Yes.
where we are.
So Anthem has assigned 2 lasers on 2 of your members. And I got some notes on those. I'll talk about them in a minute. So just kind of understand that as we get into the projection going forward. Interesting below in the second box, we had in the current first column, right? The current year, 4.7 million on 32 members over 50,000. We now have almost 5 on 51 members. But with that, fewer are over the 150,000, right? So that's kind of what happened in the box above, right? We backed out fewer large claimants. And then there's the excess amounts which equal above. We do not include that non-enrolled large claimant in the second column, right? So that 1.693, the 5449 would be higher by 234,000, and the 1693 would be higher by 150,000. 80,000. So claim modeling. So what we do in this third box is we do the actual work to project the claims. And we referenced trend earlier, so that number will come up. But the very first line that you see in the first column is 20, and the second column is 19. Those are the number of months that we're projecting forward, right? So if annual trend, if you look below, in the first column is 8.63 and 7.84 in the second column, that's what we expect claims to increase based on lots of different factors, right? Cost being one of them, utilization being one of them. As people get older, right? All that gets factored into trend. And that's the predictive trends. And we've been in this like 7-ish to 8.5, even as high as 10% the last 3 years, right? Drug trends are driving a bigger portion of trend than they usually are, but drugs overall smaller spend, right? So this year we're at probably 7.5 for medical and about 11.3 for drug, and that's averaging out to be about 7.84%. What does that 20 and 19 mean? So I'm not trying to predict claims a year from now, right? I'm trying to predict claims all the way through June 30th, 2022. So in the current budget year, when we use claims for October, we're trying to say, hey, what are those 12 months of claims? What are those going to look like 20 months from now? So I have to take my annual trend and convert that to what we call an effective trend. right? And what that basically does, so I'll do the easy math for you. If annual trend instead of 8.63% was 12, right? This is just rough. It's not the actual way we do it, but if it were 12, it'd be 1% a month, right? 1% for every month of the year, 12. If we had a 20-month trend period, then that effective trend would be 20, right? So basically what we do is we take trend and we're saying how many months out are we trying to predict, and that's how you would do it. It works out a little different than that, but if you take that number, divide by 12 and multiply by the number of months, you get a number that's pretty close. So we take our per capitas, we increase it by the effective trend, and we get a trended claim number on a per capita basis. If there was reasons to add margin in, we would. I'm not adding any margin in. We get our new projected claim number, number of employees on the plan. So we are up this year from 519 to 530. So we're up 2%. We get a new projected claim number. If we had any benefit adjustments, we can adjust for those here. In the first column, you'll see the second to last number, 0.9830. I said before, we always try to get the Anthem's claim projection if we can. What this shows you is that is 1.7% off of what Anthem was expecting for claims. And we just basically, so that we keep the budget similar to the employee rates, we just force to that number. I'm not concerned on, $11 million. I'm not concerned about 1% or even 2%. So if this were a 5% differential, then we'd be working with Anthem to find out why are we so far off, okay? And we've had to do that sometimes. And usually there's some reasonable exception, and we account for it either on our side or on their side. So your projected claims for this year, 11.3, and then that would go to 12,751,000. Now, the note above, and then kind of repeated here, what we decided to do based on the health of the reserve and based on where we are, so there's some next steps to come up, but before we get to those next steps, is we've decided that instead of, so in that box above, right, where I backed out 793,000, I'm assuming those two laser individuals are still at 150,000. Okay, so I only backed out 150,000 for those individuals. The extra $300,000 in laser liability that you have on those two members, we've decided to use our reserves to offset that liability. So because your reserve is in good shape, based on the history that you've, budget history and your budget strategies, we've decided instead of burdening the claim projection with that extra $600,000 in potential claim risk, right? We don't know if it's going to happen, right? It's just based on what Anthem thinks is going to happen. Then we're going to use the reserve to offset that liability.
Is this the first year that Anthem is imposing that laser calculation?
It is.
Okay. And
In the private sector. Let me say this, in Connecticut that I'm
Public
aware
sector.
of, in the public sector, sorry, in Connecticut in general, I'm aware of. You in the private sector, I don't think they've implemented lasers until this year as well. But across their enterprise in other parts of the country, they probably have done it before.
So I just want to clarify.
Yeah.
The use of the reserve. It's not as if we're going to identify that in the budget and say, we're going to take $300,000 or from reserve and move it to
Correct.
offset. What we are doing is we are assuming risk.
Yes.
We don't know whether we're actually going to have those costs or not, but if they do materialize and those costs are there, the anticipation is we would use, would make a transfer at some point into the active account from reserve to the operating budget. Does that make
We
sense?
really got to put a dollar value on that so we kind of, in our mind.
300,000?
It's 300,000. 300,000 is the cost.
Yeah.
That's a visit too, so.
But right, it's not going to be a budgeted number. It's going to be an anticipated potential claim against the reserve.
So Joe, the lasering means that right now the stop loss at 150, anything over 150, Anthem pays.
Yep.
Correct. So the lasered people means they have to get to 450?
Correct.
Okay, but they'll still pay over the 450.
Or yeah, at 450 you'd be done. They'd pay over the 450.
So the potential for the reserve then would be it would be actually 600,000, not 300.
Yeah, 300,000 times two.
Okay.
Yeah.
Make sure we're on the same
That's
page.
why you're the king of the spreadsheets, Mitch.
Yeah,
Just trying to
that's
make sure everybody follows it.
But can I add a couple quick questions on
Yeah.
this? This is awesome. I presume from the general tenor of the presentation that they're imposing this reduction in their risk as a stop loss carrier without any corresponding reduction in premium.
Yes.
Fair assumption, right?
If so,
Okay.
here's, I think there's a bunch of problems with this, right? And Anthem has heard it from me many times. We've had some, what I would previously call high level, which I understand now are mid-level meetings with decision makers. It's a public meeting and I'm fine with making this statement. What's happened, I think, in general with Anthem's positioning is, Anthem used to be, if you go back 10 years ago, after even more, right, when Anthem kind of bought the local Blue Cross and Blue Shield, Anthem kind of ran, it was a large enterprise that ran a bunch of either state or regional companies, right? And so Connecticut, our service team in Connecticut, we had underwriters, customer service, sales, VPs, presidents, right, all here in Connecticut that were responsible for Connecticut business. You had your own dental people here, you had your own life insurance people here, your own prescription people here. And what's happened is Anthem has become a large enterprise. And they've really siloed out all those different entities, right? So now there's Anthem Dental, right? And they're out of Colorado, I think. And it's fine that they do that, right? They're a big company, they can make those decisions. What we're really seeing now, though, is every kind of line item within their every department within their entity, their enterprise is becoming its own division. And stop loss has become one of those.
So can I ask maybe an unanswerable question, but sort of, this year it happens to be 2 people. Next year could be 3.
Or 0,
or
but yes.
0, or
Yep.
5. We'll know after 10 years what our likely trend sort of target would be. But is there any way of looking back to sort of kind of guesstimate what we would be looking at? Or is that just completely random depending on the quality of the large claims?
Completely random based. So what we will start to be able to do, right, is have more data to understand, okay, of these 51 large claimants in this projection, right, what about those that are at 55,000? Could they potentially be lasered at some point in the future? So a better understanding of all those large claimants and where they're going will be important to understand.
And how many other stop loss carriers are in the market?
Lots. So that's one of the next steps. Yep. So one of the next steps
We're going to
is
get
we
to that
are.
question
I'm
as
sorry to
well.
keep jumping.
Yeah, no, that's okay.
Yeah.
No, so that's one of the next steps. So I think it's fine to do that right now. So 2 things that are happening. One likely today or tomorrow. I think we have everything but one piece of data left. Is we will be releasing a full RFP. So we call it a market check, but it's basically a request for proposal that we will send out to all of the players in Connecticut to say, hey, would you want to be Guilford's Anthem, right? Including stop loss. Please price our stop loss. In addition to that, we will also be doing a separate stop loss only quote. So both of those are features that we can have. So your question, how many stop loss vendors are? There's many. There's probably 7 or 8 that I've seen in the last, 5-6 years that at least understand this market enough that we'd probably be talking to. You're not the only group dealing with this issue. So the stop loss laser is impacting, I would say it's impacting all municipalities in the state, but not everybody's going to get a laser because not everybody has a large claimant that needs a laser, but it could impact anybody in the state. They're not just picking on Guilford. So I've got 4 of my Anthem cases I'll have lasers assigned. So far 2 don't, and I'm still waiting for a couple more. So we'll be also looking to shop that. There's a couple ways that we do that. One, we'll shop everybody individually, and then we'll talk to them and say, hey, if I was to bring a block of business to you, right, does that change the way anyone stop loss vendor might look at that? And there could be good and bad with that. They might say, yeah, we'll do that, but that means Guilford's going to pay less than somebody else, and maybe that somebody else will want to pay more, right? So we'll look at it, right? It'll be something we'll look at. There's also CREC runs a stop loss it's not a captive anymore, it's a coalition now, so we'll look at them as well. So we'll have options to look at. Before we leave that topic, one of the reasons why most public sector groups use Anthem for their stop loss if they have Anthem as their carrier, or Cigna for their stop loss if they have Cigna for their carrier, is because Anthem and Cigna didn't do lasering.
Yeah.
Right? it's one of the main reasons. There's really two main reasons. One is lasers, and the second is what we call cash flow. One really good thing about having Anthem or Cigna be your stop loss vendor is when Joe, that $150,000 claimant, hits 150, they stop drawing claims, right? So Mary Jane forgets all about Joe, right? Joe's done for the year.
One adjusting company.
Yeah. If we have a third party vendor, Voya, Berkshire, anybody else, then Sun Life, what'll happen is we're going to still pay claims on that claimant, and then every month have to
Submit a
get
claim for
reimbursement. And they do it quickly, but here's quickly. It takes me a month to get the claim data, right, after they've gone over, and it takes the vendor at least 2 weeks to usually kind of, yeah, we agree we should pay you on this. So it's a 6-week turnaround time. Might not be a big deal for Guilford. For other groups, it is, right? And just to put that out there, I had actually got negotiated on a $1.8 million claimant for a client who had a third-party stop loss vendor. It didn't all come at once, luckily. It was like $600,000 at a time, but they were paying and had to get reimbursement every once in a while. So that'll be something we'll definitely flush out and understand. Again, I think you guys are probably in a different spot than most when it comes to that.
Excuse me, Joe.
Yeah.
So, you mentioned Anthem and Cigna up until now had not laser. Is Cigna also lasering?
Currently, they are not.
They're not.
So what I would expect is that, we would see, so take a step back. What I would expect to see from Anthem is we're going to implement lasers and your premium's going to go way down, right? So we're giving you $300,000 per person more in liability on these two people, so $600,000. The rest of those people, your stop loss premium could be lower now, right? Because you're now absorbing $600,000 at a minimum in your head, right? Premium should go down $600,000, right? And that's not what we're seeing. We're actually seeing Anthem's position being looking for an increase on the stop loss as it is and implementing these lasers. They've come off of that a little bit, but not enough to satisfy us. The other thing that I will say that's mostly troubling is there was a little indication on 2 occasions over the last 18 months where there was some laser discussion, like something came across, that just kind of heightened my awareness. We've specifically been asking Anthem for the last 18 months, are you planning on doing lasers? Because if so, I need to know before December 6th, when we sat down to do, was it December 6th? Before we sat down to do our budget projections, right? I need to know in August so we can start to prepare for this. No, don't worry about it. And boom, the first renewal I got from Anthem had a laser in it. So beyond the fact that we're not happy with lasers in general, I'm not happy that I'm getting a laser and an increase. I'm probably equally disappointed in Anthem's rollout of this, right? If they understood their market like they pretend to understand their market, they'd know that they need to give people a heads up. Supposedly I'm being asked to, I said I had a mid-level, which I thought was a high level. Supposedly we're being invited to even a higher level conversation with Anthem on all of this. So questions on the projection? I have some observations that might help with talking points, and then we can add any that we think are necessary. But so just kind of what's happening in the market, here in Guilford. Your gross claims are up 13.5%. That is higher than what we're seeing in the market, right? I've got a couple other clients in there. I've got 3 groups that I'm probably looking at decreases this year, right? Not 15 to 20% increases. Your large claimants, so claimants over 50, they're up $750,000, right? That has an impact on the projection of $840 because of trend. So of that increase, right, 7.43% of your increase is associated with those large claimants over $50,000. Your excess claimants over 50, despite the large claim increase, we're removing $740,000 less in excess claims. So we have more claimants over 50, but aren't going over that stop loss. I'm not taking them out. That's another 7.43%. You can't really add those two numbers together because part of them are the same people, but it's some kind of a blend of those two numbers. And the overall large claim change account for the entire increase, right? So really what's happening is because of what's happening in this bullet, that's most of your increase right there is these large claimants. However, right, the increase of, it sounds like not a lot of people, right? 11 people. that's worth $265,000, right? So to have 530 people instead of 519, that's 2.3%. So had we not had the increase in large claimants, we weren't dealing with all the stop loss issue, and we didn't have an increase, we might be looking at a flat or a decrease, right? So you can see where other groups might be saying, oh, we're flat or very low single digit increases. It's really these large claimants and your increase in enrollment. Your reserve levels are favorable based on historic reserve strategy, and you're well positioned to assume those laser risks at this point, if necessary. So that last bullet did a better job of saying what Matt said earlier, right? Your reserve is well positioned to assume the laser risk if necessary.
You said it.
And then lastly, we already talked about our next steps.
So the increase in current enrollment from 519 to 530 is from the year we're in right now, 21, 22 to 22, 23, or right now we're at 530?
As of November, you were at 530.
Okay.
So that's who was enrolled in, and then that's compared to as of October of
The year
20.
before.
Yeah. And that's what the budget was based on.
But unless we see something that's gonna indicate, well, a whole bunch of people are being added, we use that number
Right.
for next year's budget.
Right, because we
Yeah.
did an unusual growth in staff, which we don't expect to do, at least.
Well, remember, this is also Board of Ed.
Yeah, it's also
Yeah.
Board of
And
Ed.
no, when I say we, I
Yeah,
meant
yeah.
the whole town.
Global.
Yeah.
But 11 is a lot for, I mean, my lifetime here, 11 in 1 year is a lot.
Remember
It's not-
that, Sandy,
But
sometimes,
it's not just all brand new employees.
Right.
It could be, I was on the waiver and now I got married and my wife, and, now I'm on the health plan. It
vice
could be
versa, some
changes.
26.
Okay.
Right.
I'm not even being critical of the
No, just-
11.
I just want to explain the number. It's not to say we hired 11 new
It
people.
fluctuates every month.
Okay,
It goes up and down every month. I'm either adding somebody to the waiver or taking somebody off the
Yeah.
waiver. Lifestyle changes, people retire, leave,
So,
and we hire
so,
people, so.
to really understand the nomenclature that you used before, this is not necessarily the number of employees who are on the plan, this is the insured body.
Correct.
Is that the right phrase? What's the term of it?
These are the enrolled, these are
Employees.
enrolled employees
These are
or
enrolled.
retirees on the plan. So, you probably have, between the town and board, you're probably about 700, 800 total employees, right? The rest are waiving.
Right, but this is employees, not people on the plan.
Covered live.
Yeah, not covered lives, that's the.
Correct,
So
that's
I'm-
members.
I'm one of this number, even though my husband is also on. My husband's not in this number, only me.
Okay, okay,
Does
got
that
it.
make sense?
Yes,
Yeah.
it does. That's
And I
what
think
I'm
it's
just looking to
about 25-75, is that what the split is? Approximately?
Approximately.
Yeah, so you're about 25%, town's about 25% of that, the board's about 75% of it.
But does that family situation work in the calculation? I mean,
It does.
It's not in the growth numbers, but is it in the calculation?
It is. We saw that earlier on in one of the slides. Yes.
Yeah, and so I said before, right, that claim projection, this summarizes, so when I do the projection, I do it both ways. I do it based on members, so counting Mary Jane's spouse, and I also do it just counting employees. And if there's a big difference, then I'll either change the way this exhibit shows out, or I'll note somewhere, right, that membership is driving a bigger increase. The reason I tend to just do employees is that's the way the industry does it. And it's also what you're more familiar with, right? If I say 1,500, you're like, what is that number? But if I say 530, you know that number.
We have historically budgeted based on the number of employees or the number of
Yes.
contracts, as we call it. So in our deliberations, we have those discussions when we are going over the budget, and we have chosen to continue with that strategy so that we have consistency from
I'm
year.
more concerned of what the insurance company is thinking, because their claims, which is naturally, their rates are based on their claims, calculates in everybody. I mean, you could have a child that could spend $1 million.
Yeah. So that's,
Tragic birth.
they're all in the claims, right? So that's all in the claims. It's just really more what,
Well, that's what I'm trying to get to is. the
yeah.
Insurance company is looking at the big picture.
Yes.
They don't care about who they are if they got to pay for it.
Yeah, but it's really how so the only difference, so the claims for everybody are always included. It's just how are you establishing your per capita, and then how are you going to project that per capita? And you can use either members or contracts. And where you might decide if for some reason, so I'm trying to think of an example, you could see a big decrease in the number of employees, but not a subsequent decrease in the number of members. So let's just say this was reversed, right? We went from 530 to 519, but I didn't see a drop in membership because those people who dropped were single, right? And got replaced by single people. And so my membership stayed the same, or I've even had cases, I think this happened to us once here, where our membership didn't change at all. We had a drop in employees. And so we would then say, well, we don't want to take credit, right, for dropping employees if the number of members isn't changing. So we look at it just like the insurance carrier would, but we factor that in before we kind of get to that page.
So Joe, we show, by 11, if we go back a couple pages to claim history, our average experience period members, the numbers, 1341 versus the previous year, 1323. Is that it? So.
That's counting members. That's counting Mary Jane and her husband.
Right. So we went up by 11 employees, but 18 covered lives. So less than 2.
And that's, and the thing is, be a little careful there, Matt, right, is these are the page you're looking at there, the 1323 and 1341, those are running, right, throughout the year. The 530 and 519 were snapshots in October, November. These are actually averaged on this page. So this is a more accurate count historically to do the average. But what we would say, so we actually spent a lot of time talking about what enrollment number to use. And so like the 519 and the 530, the board might say, hey, wait a minute, that 519 is high, right? Because we just lost 10 paraprofessionals, but they're still on the plan in October, but they're coming off in November. I'm making this up, right? And so you could drop that by another 9, Joe, or the opposite. Hey, Mitch said we're going to hire a whole new bunch of plow drivers because of what happened this year. So we're going to hire 20 employees next month. We need to add to that 519. So we will adjust that if we need to. That's really important, right? The last thing you want to do is under project the number of employees.
I think one thing that Joe pointed out at the end here that people, the board should be aware of is that we're not just looking at stop loss for the RFP. We're looking at potential. Doesn't mean it'll happen, potential changing away from Anthem. If that happens, it'll be a seismic shift in our employee. There'll be real issues with that just from an employee standpoint. But if we can show that there's savings, hopefully that makes up for some of the disruption, if you will.
And
To that point, Mitch, do we have to reopen contracts? Is
No.
it plan specified?
I don't believe so. We can talk to Chris, but we've got language in there that I believe protects us, that it has to be substantially similar or comparable. It doesn't say, it does say Anthem is the current provider, but we've got language in there that should take care of it. If we get to that point, we'll be looking at that and having to discuss it, and there'll be a lot of information sessions with the employees to say what does change and what doesn't change.
And one of the reasons why I said hopefully today or tomorrow, we decided to go out to bid 4 weeks ago. Why does it take so long? The amount of data that we pull out together so that the carriers can do a thorough analysis, because the last thing we want to do is say, hey, United Healthcare is going to be a great replacement, and then find out half of your providers aren't in the network, right? Because that's not going to fly. So when we present our findings to you guys, we kind of do it in 2 stages, but at least by the second stage, not always in the initial, but by the second stage, we wouldn't have United on that page, right? If there's a 50% drop in because we know the unions won't go for that, right? That's not substantially equivalent or comparable. So you would have all of the data. And what we tend to do is if you guys are going to make a change, we tend to kind of coordinate those meetings. Like we come and meet and say, hey, here's how we did the RFP. Here's what everybody said. Here's your actual by doctor, right? Not just how many doctors you have in the network, by doctor, right? How many people were, if Dr. Jones comes out, how many people did he see, right? He saw 12 people, right? And by the way, he's in Florida. So is that a big deal or not? Might be, it might not, right? So all that analysis we do ahead of time.
When a potential change like that happens, other than rates, is there a calculation of the cost of a change?
So you're talking about the manpower, the attorney's fees.
Or even just fees. I mean, everybody's faced with it. I know the teachers union just made a switch and everything, and that's got to be a pretty big number just to do the transition. I mean, all the paperwork change and all of that. is there a set number that is included in a calculation of simply rate savings?
No, and so let me see if this helps. So it used to be, right, that public sector entities wouldn't even consider making a change unless there's a 5% savings, right, to just make a change. And then that was even at some point not enough. What I will say now is that, and there's kind of more to the story. Mitch could probably give you a whole meeting on. We've had other issues with Anthem, right? So we don't just have stop loss issues. We have other service issues. Your retirees especially, we've had problems with.
We've had a lot of issues in the last 12 to 18 months with Anthem that have been very, very disconcerting.
Obviously.
On our level, I say our level, I mean this floor level, but some have trickled down to employees and retirees to the point where they are seeing changes in service. So there's some real concerns.
I know there's changes and, you know, it's easy to say, okay, we're gonna get rid of them and get somebody else. That's easy. The hard part is getting somebody better,
Yes.
other than just strictly a percentage of rates.
Yeah.
If we can't, we're not gonna, we won't make the change unless that's true.
Where I was going to go though is I've had clients over the last 5 years change for no savings, right? And just throwing this out there, that might be something you guys are faced with, right? So maybe Cigna comes back and says, we're not going to be any cheaper than Anthem, but we're not going to put the lasers in, right? So that to me is a potential reason to make a change. So you might not see any dollar savings, right? But you see that one change in their position. And after Mitch and Mary Jane and the board and Matt and the board get to meet with Cigna, they say, yes, and I'm just making that up in a public meeting, right? But, you know, it could be United, whoever it might be.
Disclaimer duly noted.
Yeah. You know, but so those will be one of the things that you would analyze, right? Is what is the impact to us? Who is the best partner for us long-term? And is there financial savings or not? And if there isn't, right, is it still worth a change? And it might be. So I don't think financial is the only reason you'd make a change, but it tends to be the major reason.
And please don't take this personally, but this is more work that you and your company do for us, I think, than in a regular year. But I know you have a contract with us because I was part of the last negotiation. So everything you do is included. Is there anything over
Correct.
and above?
Nope. No, we're not paid any more or less based on this. And we're not, just so you guys know, we're paid by you. We get paid through Anthem, but it's a fee that we negotiate with you.
Right.
And we don't get any Anthem bonuses. We don't get Cigna bonuses. If we move you from Anthem to Cigna or to United, there's nothing changes in my life. I do a little bit more work and get paid the same amount, but that's okay. No, that's okay, but.
You're doing this for
Yes.
multiple plans.
Yes.
So it's,
And Joe, you mentioned there's a number of stop loss carriers out there, because I've seen advertisements and solicitations from plenty of them. And we've talked about it over the years. But as far as the overall full carrier replacement, it's probably only 3 or 4, you think, in the state?
Two big players in the public sector are Anthem and Cigna.
Right.
Cigna's picked up quite a bit of Anthem business, not as much over the last couple of years. Connecticut is up there. Connecticut tends to do more fully insured, smaller group sizes, but they'll definitely be a player here. But Aetna and United are both making a strong push to get back into the public sector, especially United. For many years, while United was working with the state on the partnership plan, they did not participate in a lot of public sector RFPs. They will be participating, I'm sure. I can't tell for
Okay,
sure, but
just curious.
Yeah.
I have a question about the laser, which I think I understand. So we're saying that we decided or we're considering funding it out of the medical reserve this year. This is not a one-time thing. As long as we stay with the plan that has lasers, this isn't every year we're gonna have a few. So we should be aware of that when we're deciding, we don't have to take it out of the medical reserve. We could put it in our budget.
correct.
So we're considering doing something that's might potentially hurt us a year from now, aren't we? By making this decision about the medical plan, but we can't be doing that
Might hurt
forever.
us both years. I mean, no reason why a high, a high thing couldn't go on for multiple years.
We expect it to.
Well, that was my question of
So we're
what do we
taking out-
think is gonna happen year
Yeah,
over year,
I
and when
mean,
do we know what a baseline is?
Right, it's not a one-shot thing.
Yeah, it's not
Just by
600, it
taking
could be
out the reserve.
6 million.
Well, then, we would.
Well, if you got 10 people.
We'd be having the same
So-
conversation.
10 years, 10
We'd
years.
be having the same
10
conversation
years,
here
retiree.
and deciding whether or not we want to continue that or put it into the
Yes.
baseline budget.
At some point, we have to confront that question. The question is, now, next year,
Right.
for 2 years.
I guess I'm just saying, let's make sure we make a conscious
Yeah.
decision. Let's not just say, oh, great, we can take it out.
Well, not only that, I think we gotta compare it to increasing our stop loss.
Yeah.
I mean, that's the
Yeah.
big comparison right there. I mean,
Yes. It's
risk
similar to that.
versus you covered yourself.
Exactly.
And if
Right.
you're only talking two, that might be a valuable option. If you start talking more than two, that's gonna be expensive.
So Joe, when they laser, they're actually lasering individual
Correct.
members. It's not a case of if you get two people that get to this point, the first two that get to 450. It's actually two individuals.
Yeah.
If one person.
Joe and Mitch are lasered. If Joe leaves, then he's not worried about it.
And then they-
Increase stop loss for individuals like laser, or if we would have to increase it across the board to cover those.
Yeah, generally the carrier will laser the individuals.
Right.
We wouldn't pick
We
to,
chose not to laser, that we chose to increase our stop loss.
oh, just to go to their laser level. In general, so let me say this, it would be interesting to
And we laser them.
play that out. If, let's say we went from 150 to 175,
No, before,
right, but if you went all the way to 450, that would be on everybody then, right?
so we cannot laser our own individual.
No, I mean, you could, we actually, a few years ago in another client, we have a very large claimant every year. And we were getting some pretty big hits on stop loss. And so we proposed to Anthem, what if we implemented a laser? And they did quote it for us. It worked out as exactly as you would expect, right? The premium savings was about their liability. It was about the liability you would get. So now that may be different today. But I would say in general, you respond more to them lasering than you kind of voluntarily doing it. But again, we did propose that once.
And I'd just like to throw out to you guys who are making these decisions, another option for us is to do it this way with taking those two out, but in the medical operating budget, budgeting for some of that. We often budget for something that to answer your question, yes. So we could say, we're not going to include it in our overall medical claims, so to speak, but we know we have this other 600,000. Well, so maybe we're going to budget 300 in the medical fund, in the operating budget.
Earmark it for those two.
Correct, just in case it's needed. So year over year,
But you're defeating the purpose of what we're trying to do.
I'm just giving,
Which is, because you're still gonna have overall costs. You're gonna be layering back in the overall cost of operation, right?
yeah, I'm just trying to answer her concern about budgeting. So maybe it's not the 600,000, maybe you budget 100,000 this year, or I just throwing out, I'm not saying that's what I'm lobbering for. I'm just,
Budget for it, then I think we have to show the anticipated expense, right? Or are you saying just budget for it without the anticipated expense?
I'm just thinking off the fly here. Right.
If
Right.
you adjust it on one side, you've got to adjust it on the other side, right? Or are you just using surplus to
Yeah,
fund?
are you
Right.
saying that we could just earmark a certain amount of medical, because we're starting to look at, the level of the medical reserve? So are you saying we could earmark part of that can't get touched? Is that what you're?
No, that's not what I was saying. So,
I
yeah.
know what you're saying. So
I get it.
if our medical budget was gonna be $3 million, we could do 3,300,000 as a line item to anticipate some of that expense versus let's rely on the potential risk protection from what's in reserve. Those are the sort of
Yeah, it was just another,
two potential options of a
Right,
number.
I would be a little leery about double dipping, right? Because
Yeah.
we're gonna be lasering those two individuals, all right? So we're taking anticipated costs out of the mix, all right? And then we're taking an additional amount from fund reserve to put in the medical account, all right? And if it shows up, we use it. If it doesn't, we don't use it, right?
Right,
but it would have gone as an expenditure.
correct.
So I have some concerns about that. It's almost like double dipping.
No, because it's not in your we've already taken it out of the medical, but just that money that we may pay, some of it, we're gonna budget for the, or on the other side. So
Okay.
it's not in there twice, but I was just,
Right.
I wasn't lobbying for anything. I was just trying, I could see, I understand the concern, because I always have that concern. We're gonna take $600,000 out of the medical surplus this year. What happens next year? You know, we're already, now we've made a $600,000 hole for ourselves.
So, and the reason we're doing this is because we are now assuming a level of risk we're here for, we did not have. All right, and we're going to analyze that next year, this time to see whether or not we should continue to do this, this type of analysis. And if we do, then we probably should budget for it. Right, if it's going to be a long-term trend, then we have to budget for
Right.
it. And not necessarily always out of the fund, the reserve fund.
Correct. I think we're saying this, I think we're saying the same thing, just, you know, coming to that number and that philosophy is the discussion, but
This is a question that came up at the presentation with the Board of Education, and I was pretty quick to dismiss it. And I think you supported me on that, and that is, what about looking at the state of Connecticut's plan, the municipal plan that they put together, partnership plan?
Yeah, so we can look at that. So as part of the market check, we call it market check, you guys call it, we will also do an analysis on that. You know, we could probably come back and do a whole presentation on that. There are some concerns about how that plan is funded and its current status. So that would be, I think, a consideration you'd want to make. But it would be part of the analysis. We do know, so initial guidance from the state, a little troubling. So initial guidance from the state was groups should plan on an 8% increase this year, the state partnership plan. That then got reduced down to 4%. Because the state got nearly $50 million, I think it was, from COVID relief that they actually put into the state partnership plan fund. The actual guidance then just got formally released. It's not the final number, but their initial guidance is now 8. So they went from 8 to 4 to 8. So come to find out, the initial guidance should have been 12, not 8, and then down from 12 to 8. So there's some concerns about that. You know, there's actually, and like I'd be happy to come talk more about that. Brown and Brown, they're a consultant. They do what we do. They did a study with CBIA on the long-term outlook of the partnership plan. There were some concerns there, but the state has a response to that too, and we'd be happy to kind of go through both of those things.
I'm a little suspicious of the plan on a number of fronts. What's the real number? The fact that they're utilizing one-time funds to prop it up. Now, this plan became very popular with communities like Guilford because we were facing 12%, 10% rate increases. They went to the state. Oh, we're going to save you a bunch of money by going to the state. Well, their claims experience data didn't change. So that put the state fund almost underwater, if I'm not mistaken, at one point.
There were some bad years. So what Matt's right. If you look at historically so the way the state plan runs is it's one set rate by county now. It used to be once, I don't know where we were in negotiations, but it used to be one set rate for the entire state. Now it's adjusted by county. So Fairfield County is the highest, not as high as you'd think it would be compared to others, but anyway. And so everybody in that county get the same rate. So if let's say Guilford and Madison, the exact same plan, right? Exact same plan today. You guys are 13 million in claims and Madison's 15 million in claims. You guys both go to the partnership plan, you pay the same rate, right? So it's not all adjusted for your own claims. Additionally, that plan is more generous. So it's not a high level health plan, it's a copay based plan. And so let's make it up. Let's just say your 13 becomes 11. And again, I'm totally making that up. That $11 million, we wouldn't expect your claims to go down $2 million by moving from an HSA plan to a copay based plan. And certainly not the bigger number for Madison. So what we tend to see happen is groups that can save money versus current migrate to it, and you don't necessarily see that claim offset. Now, the exception to that is there were a lot of little groups, very small groups, 70 employees, 30 employees, who one of their issues is because of their size, their cost was very variable, right? So they get a decrease, then a 12% increase, then an 8% increase, then a 15% increase. And so it became really hard for them to budget. And we saw a lot of those groups migrate to the partnership plan. And so, there's some analysis there. Those groups aren't making that same financial decision. They're looking more for stability than they are for savings. There's a lot of data out there, and we could spend some time talking about that. But we will look at that, and so that could be part of our review when we do the market check.
All right, Joe, that's
That was
exhausting.
impressive.
Yes.
That was impressive.
Very, very easy though.
Well, hopefully it's helpful. I'd rather not have to come see you, right? If it were like the previous months, previous years, you'd just say, hey, went down again. But yeah, thanks. See you later.
And if nothing else, Mitch and I like you to see this work,
Yeah.
because this is all the work we're doing on these budgets every year. This year we are bringing it forward to the boards because it's an exceptional, but, and this is only a small portion of the data that we look at. So just so you know, before we come to you.
Yeah,
Yeah.
Really here.
yeah.
Yeah, I know, but, before we come to you normally on a regular year, this is all the work we're doing behind the scenes. So, it's good for us to show you that. We tell you that, but, you believe us on blind faith, but here,
Well,
here's
it's an
the
exceptional
work.
year, and I
Yeah.
just felt that Joe's presentation
There's
was
gonna be a
much
lot
better
of-
than Mary Jane and I could do ourselves.
Yeah,
We're gonna get a lot of questions, from people, about this topic, so it's
Yeah.
helpful to have some ammo.
Yeah.
Sandy, are you comfortable yet with the rationale? Why?
Yeah, yes,
With the HSA?
yes.
The HSA, it is not the HSA that's
Yeah.
causing this. It is the trends that were created as a result of going to the HSA, which was all ran across over time, and now that curve has stopped, leveled out, and regular healthcare costs.
The new baseline.
In fact, are gonna start, so.
Yeah, and the large claimants
And the
aren't
claimants.
helping you, right? So normal large claimant years would be,
Claimant issue is an issue for Guilford, so that's.
Yes.
Guilford, but it seems like Anthem has just made a corporate decision to raise rates, period.
well, their approach on stop loss has completely changed, right? So that raised rates, I'll isolate that from, I don't do a lot of fully insured business with Anthem. Actually, I don't have any fully insured business, so I'm not sure what's happening on their fully insured side. Where it's impacting my self-funded clients is on the stop loss side, right? They're looking, and in general, when I look at I call it book of business. When I look at my Anthem clients, they haven't lost a tremendous amount of money in general on my clients. Now, if they're losing money elsewhere, I don't know. So if that's driving it, that they're losing money overall on stop loss, I'm not sure. It's one of the things I hope to find out.
Well, I don't know if it's a losing money corporate decision as much as, cherry picking.
Well, yeah, I think the policy discussion over insurance companies could go on for another
Yeah,
25 years, and it may.
yeah.
Before we conclude, Jonathan, I know this is you're on the line. I assume that you would, if you have any questions, you would have asked or put your hand up or suggested. Jonathan?
I guess I just have maybe one kind of large question. I was curious about what made us sort of over budget over the last couple of years. I'm not sure if I'm getting a good answer there, just maybe because I don't even understand it all yet. But then I think I'm understanding, where we're going with the lasering and some of the higher premiums for the stop loss.
In terms of over budgeting, I think over the past couple of years, several years, we didn't really fully realize the impact that moving to HSA would have. We had assumed by moving to HSA that we would stop a trend of increases. But the program, I think, was more successful than we had anticipated it to be. And that's why we wound up with some of those surpluses over the couple of years. So I don't know, Jonathan, if you have access to the spreadsheet, but Now, if you take a look at the total spend over those years, that's largely how we built a surplus. And let's not forget, 8 or 9 years ago, we actually had to put money in to supplement the plan on any one given year. I think we had to put $500,000 in or more,
Time flies, it was 2013.
2013.
That was pre-me.
That's 9 years ago, right? So Jonathan, I think, it wasn't an exercise where we purposely or strategically said, we're gonna over budget and build a surplus. What we did was we were budgeting in a different era where a different type of insurance coverage had been introduced, and we were less than accurate. But the good news is it was wildly successful and created those surpluses that we've got there to draw on when we have unusual years.
Yeah, I think some of it, if it's okay, some of it too is a function of when we do projections, right? So like if we just said, hey, this projection's good today, right? We're done. We're not going to keep update. We still look at it. Lots of things can happen between now and the end of the year that don't always get factored into the projection because your budget's already set. And that does include migration to new plans. So, and that's, specifically when, like the teachers moved over, right? Those negotiations were ongoing when we were doing the budget. Same with the non-certifieds. Mitch's negotiations sometimes go until April or May.
Months plus.
Yeah.
We're also trying to budget, as we are right now, anywhere from 12 to 18 months out.
Right.
And it's hard to predict. And to Guilford's credit, he's been on the conservative side of the budgeting.
Yeah. But I think I think Matt, a combination of those two things, right, is the migration to the HSA is not fully accounted for in the expected claims. And it's been realized through careful planning negotiations and perhaps even some luck, right, where it's outperformed even what we expect it to be.
And of course, the COVID year.
And the COVID year doesn't help us at all.
Well, it helps us, but.
Well, it doesn't help the
But
projections.
as far as the savings from that particular time,
Yeah.
period, which no one predicted 18 months out.
Correct.
Yes.
To Mary Jane's point, in fear of dating myself, I remember when the fund balance was dangerously low. It wasn't that long ago.
It seems like it.
When would we have the December figures? Just because then we have like a 6 month into this year.
We should have that. So actually that'll be something as we update when we're actually with the RFP, when I get all that data, that'll be something I can update at that time too. I know early indication was it did not look
Yeah,
as good
if
as
you,
November.
if you look at the projection that I provide on a monthly basis, my December claims are over 1 million. Is it 1.1? I forget what the number was, but it was over 1 million.
Pull that up before.
Yeah,
And you probably have a set of numbers that you're pretty close to pulling together right now for January.
yeah, because my numbers are reflective of the draws on Anthem. So we have a draw on every Thursday, so we know what that is. So, that was one of the things we look at. I'm not sure if I've said here, other meetings we've had. Joe provides monthly data as well as I. Joe's doing it on a day by day basis. So when it's December 31st, it's December, closer to that. Mine are based on our draws. So that's why our numbers can be slightly different, and they are.
Yeah.
But we've never been so off that there's been any concern. But his numbers aren't going to match to mine because of that.
Correct.
I have a question. That 2020, 2021 year, we were able to hone into, it looked like a much better estimate for medical. Was that because the HSA was factored in that budget year?
No, so I don't know if you caught my comment earlier, that 2021 year, we saw continued favorable performance, bigger than that, in most of our clients. That was probably more a function of that 2021 year was completed before we were anticipating COVID. Right. So that projection would have been higher, right, had we known COVID was looming, because we probably finished that budget, with October claims through 2019 or maybe November.
Right, because we're normally making these decisions, final decisions, early December because the Board of Ed needs to report, out. So typically in a, what I'll say, normal year,
Yeah.
by that time, we have a good number, we continue to look at it, but as Joe mentioned before, we don't make adjustments to that number because the trend doesn't fluctuate enough for us to have to go back and revisit all the numbers. This just happens to be one of those exceptional years.
Yeah. So I guess the good news and bad news is, we've each, maybe a good way to say this is each of these years, right, there's been some significant changes, right, either in the plan designs or with COVID or number of large claimants. This year, even in the running 12 or the last 2 fiscal years, there's enough moving there too, where, I don't feel very confident that we've really have a clear base established. So we might still continue to see, right, some higher or lower years. It's when we get a nice base established with consistent number of large claimants that number can really kind of dial in. But what I'll say is that we do carefully look at those projections to try not to, to try to come as close as possible, knowing what we know at that one time. There's no margin put into these projections, right? We're making the projection based on what we know at that time. The biggest fluctuator there is claims month to month and then the trend, right? Every month that I add a new month of claims, I can drop trend by 1 month. If claims go up less than that trend offset, then I see an improvement in the projection. You'll remember that from the discussions we've had. But that's the biggest factor, kind of looking at claims throughout the year.
Anything else? No? Joe, thank you very much for detailed and
You're welcome.
translating this jargon.
Great.
Wonderful.
Great.
Okay. That's all. Thank you.
Thanks, Joe. Thanks. What's next?
Well,
Yeah.
we can look and discuss capital. We really don't have too much else to do today.
We want to get a jump on it, or folks want to get on to work?
Bye, guys.
Joe,
Thanks,
see you
Joe.
later.
You're welcome.
What's your preference?
I can stay.
But
I can stay for a while.
couple minutes? Yeah, good. Yeah, but yeah. Can we take a 5-minute health break? Thank you, everyone, for joining us today.
Oh, yeah, now we're back on recording.
Well, we typically do these discussions without public meetings.
Oh, right, we do.
So we gonna go off recording and we're gonna.
Are we allowed to meet together?
Oh, it's a workshop.
Yeah, it's a workshop.
It's a workshop.
We've done it before.
I move to adjourn our budget meeting regarding the health care plan.
Is it second? Call a question, all in favor?
Aye.
Aye. Motion carries. Okay.
Thanks, Tracy.
I think I can do that. Thank you.